Corey, are you there?
Yeah, I'm here. Wait.
Oh, you're there, Corey. Okay, aloha everyone. I'm Senator Moriwaki here, opening up this meeting for the Kupuna Caucus, and with me is Representative Corey Chan. Corey, say hello.
Hi, everybody.
Thanks for joining us. Thank you, everyone, for joining us. We have on the agenda today an interesting project that's running in a number of places. And I want to thank Susan Ryan, who's here. She's a CEO of the Center for Innovation, to tell us about the greenhouse project, which really is an interesting and very innovative concept of making people in nursing homes want to be in the nursing home and being treated as a real person with independence and separate, I guess, entries for their rooms and not having somebody come in on them whenever and whenever. So I was really intrigued by it because of our focus on long-term care and person-centered long-term care. That I thought that this would be good for us to hear as to what is going around in other places. And Susan is with the Greenhouse Project. It's a national nonprofit organization. And she's been good enough to come and talk to us about what they're doing in other places and how we might be able to hear from her. So is Susan on?
Hi everybody. I'm Alex Banco.
Senator, oh, sorry, yes, Senator, there was a little bit of a change. Susan had to do an emergency leave, so Alex will be here, and if you'll give me the ability, I will read off his bio to everyone. So hi everybody, it's so great to see all of you for another Kupuna Caucus, and it's really my great pleasure to introduce Alex Banco, who's the Director of Communications and Marketing. He serves the Center for Innovation, the nonprofit parent of two organizations dedicated to changing the culture and design of elder care environments, the Greenhouse Project and Pioneer Network. Alex works to educate a variety of stakeholders, including policymakers, elected officials, reform advocates, and industry groups, on the benefits of person-directed care and small home alternatives to traditional nursing homes. He is an experienced writer and editor who helped launch Skilled Nursing News, a leading industry trade publication with specific focus on finance and reimbursement in 2017. Alex's work has also appeared at the Boston Globe and the Boston Business Journal. I had the privilege of consulting with CFI for quite some time, and on the report that Alex will be talking about. And so I'm just really excited for him to be here and for all of you to hear about the Greenhouse Project and small household model. So Alex, take it away.
And thank you, Pokey. It's great to see you again. And Pokey was an incredible help and a great person in general, but also a great help in doing a lot of this work that we have summarizing. So I'm going to share my screen really quickly. Just want to make sure, can you all see my screen? Make a thumbs up. Okay, very cool. Thank you. I appreciate it. And let me play. So the title of this presentation I have is Small Tweaks, Big Change. And the reason for that is that I think a lot of us, when we think about long-term care and we think about nursing homes and we think about all these systemic problems, it can be kind of daunting to think, how can we really build this whole new infrastructure that we know is needed? Of course, after the COVID-19 pandemic, amid all of the things that we know about resident preferences, resident choices, the time is really now for change. But it doesn't have to be as daunting as we think it is. It doesn't have to be, there are very small steps. There are relatively small tweaks to the current system that you can use to encourage the development of really empowering alternatives to traditional nursing homes. I always like to remind people that the system that we have now, no one actually designed that from the ground up. The nursing home system that we have kind of evolved over the years. That was really a reaction to the implementation of Medicare and Medicaid. But remember, Medicaid was never meant to be a long-term care payer. It was designed to be an insurance program for lower income adults and families. There was really no overarching theme. It's not like someone sat down today and built this system. So with some small tweaks, we have the power to change that system. And as folks who are involved on the state level, that's even more important because there can be a lot of movement and a lot of exciting things happening on the state level. So just a quick overview of what the greenhouse is. What you're looking at in that picture there is a nursing home community. Greenhouse homes, I love having these pictures because it can be kind of hard to visualize. But in short, greenhouse homes are residential, not residential style, but residential alternatives to the traditional nursing home. Each individual greenhouse home typically has 10 to 12 private rooms, each, one elder per room, each with its own private bathroom, secured outdoor space that people can enjoy without asking for permission, a communal kitchen, a residential style kitchen where food is prepared fresh daily, and a hearth, so with a working fireplace, a table where every resident of each home, as well as the staff and their family and friends, have space to eat. And again, really trying to reimagine a nursing home as a place that's actually a home and not a facility. So again, I love these pictures because what you're looking at is, again, a room at a nursing home with furniture that folks have brought from home. There's an area out there. You see kind of a sun porch where people can gather, sit. It's a major complaint of a lot of people who both live in nursing homes and have family members there. I just went through it with my wife's grandmother was in a facility, and I use that term very deliberately. It was very difficult just to find space to sit and have tea, sit and have coffee, sit and talk about sports, politics, the weather, whatever. Not a very welcoming space. So that's a key part of the greenhouse homes as well as that design. The traditional this model originally came out of kind of a single family home style. So this is one of our communities in Little Rock, Arkansas. I love this picture because if you didn't know, if you were flying over this in a plane, let's say, you wouldn't know it was actually a nursing home community, but it is. Each one of those buildings has, I believe, 12 elders. And this is kind of the standard format. Since 2003, there are more than 400 greenhouse homes on about 80 campuses across the country. These were the first. Sorry, these were not the first, but the rural communities were the first. So there was more land. The first greenhouse homes opened in Tupelo, Mississippi in 2003. And so a lot of the early homes were in the South where there is a lot of land. But this is also a greenhouse home. This is the Leonard Florence Center for Living in Chelsea, Massachusetts, which is right outside of Boston. As you can see, it's a high rise. Each floor is its own self-contained greenhouse home. So it's very, the single family style is where it initially came from, but it has been adapted to mid-rise and high-rise applications. So if you see here, this is a mid-rise application of the homes. This is in Alabama. And one of the things that I really love here is this is an elevator lobby. So if any of you have visited a nursing home, as I'm sure many of you have, if it's multi-story, the elevator doors open up and you're right in the middle of the action, right? You're seeing a nurse's station. You're seeing, staff walking in and out. You might be able to see into resident rooms. It's not really private. But in this community, you open the elevator doors open and there's a front door, just like you would see at your own house. You have to ring that doorbell to be let in. When I, as a member of the Greenhouse Project team, go to visit our communities, I have to ring the doorbell to be let in because I couldn't just show up to any of your guys' houses and just walk in unannounced. And that's true of our homes as well. So again, here are the fast facts, and I'll make sure these slides are available for everybody at the end of this. I'll send them along to Pokey to make sure she can disseminate them all to you. But again, 10 to 12 elders per home, multiple homes per campus. So again, we're not talking about just a standalone facility that has only 10 to 12 people, but each campus, like the one I showed you earlier, will have multiple homes, either individual buildings or floors in the same large building. Private rooms with private bathrooms, secured outdoor space, residential kitchen, and a universal caregiving structure. So the CNAs, CNAs are, the lifeblood of any great long-term care community. They're providing the same care tasks that occur in a traditional nursing home, but they're also doing food preparation. So they're cooking the meals every day fresh in the home, and they're doing some light housekeeping. And there are benefits to that we'll see in some later slides. And crucially, it's not just about the structure, it's about the culture. person-directed care practices. Elders are at the center of day-to-day life. Far too often, and I'm sure a lot of you have experience with this either professionally or personally, people who live in nursing homes, they give up pretty much all control over basic things that make us human, right? When we wake up, when we go to bed, when we eat, what we eat. These are basic things, and you give up those basic human needs, little things that make you feel like a person, that make you happy when you move into a nursing home. And the greenhouse model is based on making sure that all the food menus are prepared with resident input. All of the activities are based on resident needs and wants. So those person-directed care practices are just as important as the physical design. As I mentioned, 400 homes are across 80 campuses in the United States. We have one in Australia, and we have one that's actually about to open in a couple of weeks in Canada, so we are fully international. The Greenhouse Project, the Center for Innovation, think of us as a national consulting organization. We are not a direct operator. So most greenhouse homes are operated by nonprofit operating partners, usually very mission-driven, a lot of faith-based organizations. That said, there are some for-profit operators in our network. The community that I showed you in Arkansas is actually run by Southern Administrative Services, which is a for-profit company that operates more than 50 total greenhouse homes across the state of Arkansas, and they're continuing to build. 80% are licensed as nursing homes, so fully CMS licensed, Medicare, Medicaid reimbursements, the same exact licensure and standards as any traditional nursing home you've been in. The remainder consists primarily of assisted living, but the model has been adapted to serve other populations. I always like to say that whatever has been traditionally provided in a communal setting, in a facility setting, can be adapted to the greenhouse. So the Wyoming Life Resource Center is a state-run community that serves adults with intellectual and developmental disabilities. There's the Leonard Florence Center, which I showed you earlier in the suburbs of Boston, which serves adults with complex medical conditions, including ALS and MS, as well as elders. And about 50% of the residents across the network are covered under Medicaid. We want that number to be higher. That's a little bit skewed because there are some organizations that operate as private pay assisted living. But we really do emphasize that this is not just a product for the affluent. It is possible to serve a significant Medicaid population. The operator that I mentioned earlier, the for-profit operator in Arkansas, the census of that organization is probably about the same. The Medicaid census is about the same as it would be across the total nursing home population. So 60, 70%. There's some communities that serve exclusively Medicaid populations. So again, this is not a product for the affluent. We want this to be a product for everyone. It's a baseline standard. So here's some quick benefits. We got a lot of positive press during the COVID-19 pandemic because there were substantially lower rates of infections and deaths even before the rollout of vaccines. There's a twofold reason for that. One is the private rooms and bathrooms just reduce the opportunities for the spread of germs. But the other reason is those person-directed care practices and lower workforce turnover. So in the second bullet point there's substantially lower workforce turnover at greenhouse homes because those universal caregivers feel more bought in, they have more ownership, they love what they do. And that reduced workforce turnover, that reduced reliance on agency temporary staffing is another huge part of why the COVID rates were so low. A major spreader of COVID and other infectious diseases, especially the flu this time of year, it comes from basically the more people you have coming in and out of your community, the greater of a chance there will be that someone's going to bring something in unwittingly. And so that lower workforce turnover, that lower reliance on agency staffing really helped. It was just as important as the physical design in terms of achieving those COVID numbers. More direct care time, increased resident, family, and caregiver satisfaction, better outcomes. This is one of my favorite, is that because the universal caregivers get to know the residents, it's a core value of the Greenhouse Project is really getting to know each and every resident. A big part of that is just part of those interactions that go beyond the typical care interactions, right? If you're cooking breakfast or you're cooking lunch or you're making coffee, you talk, you get to know each other. You have those moments where you get to know someone better and you can identify earlier, hey, something's not right about this resident. You know, she normally loves eating in the mornings, but she really hasn't been hungry, or she really seems out of it at a certain time of day. And so we have data showing that there's actually reduced hospitalizations because care staff can actually intervene earlier. They can detect changes in condition before they escalate for the need for a hospital stay. And that also leads to reduced Medicare spending. I know that's not necessarily a state issue, but there is a savings that are achieved also through Medicaid, as we can see later on as we move on. And also, I just love this slide here because it shows one of the big topics right now in long-term care are the new federal staffing standards. As you can see here, they're not going into effect yet, but it's a huge controversy. Greenhouse homes are already exceeding all of the standards across of our network in terms of that direct care staffing. So across on average, the greenhouse homes are already meeting those metrics that the industry is very concerned about meeting. Funding sources. So how do organizations build up? How do they build new communities? We did a survey about 5 years ago about what sort of the sources that most organizations use. Tax exempt bonds was a big one. You said they're 59%. They have taken advantage of that. Conventional lending, so banks, other lenders. USDA loans, and this is an important topic for Hawaii. It's not as well known, but USDA actually provides really favorable lending terms for new construction of nursing homes, other care facilities in rural areas. And they have their own definition of what rural is, but I know there are a lot of rural areas in Hawaii. Rural access is very important. And so there's a really powerful funding opportunity there to build new care infrastructure through USDA loans. There's actually a project that we're working on Martha's Vineyard in Massachusetts, and they were able to secure a significant amount of USDA-backed funding because you think of Martha's Vineyard as this vacation destination for the wealthy, but there's a lot of people who live there year-round. It's very isolated. It's considered a rural area. There's not a lot of infrastructure, and so they were able to make that work. Organizations have also, especially on the nonprofit side, used fundraising and new market tax credits, which is a Treasury Department program that provides funding for projects in traditionally underserved zip codes and areas. So these are just kind of a quick overview of how organizations fund. I include this slide because it really, one of the big things that I hear when I'm talking about this model is, well, that sounds really expensive, right? It's got to be more expensive to run. And it's really not, because what you're seeing here is sort of a typical, the green is the greenhouse and the blue is a traditional facility. It's not so much as an increase in cost, but a cost shift. So you see there, the big one obviously is CNAs. We know direct care is something that people need who live in nursing homes, people want, and people too often don't get. So you can see here, when you have this universal caregiver model, you're shifting money away from overhead, things like housekeeping, food service. A lot of times these things are outsourced in a traditional nursing home, and you're shifting that money to where it really matters, which is the bedside, which is CNAs, LPNs. You'll see here that life enrichment, that's another area. Again, it's not because we don't have life enrichment and activities and things like that in greenhouse homes. It's just part of the universal caregiver role. Also mentioned that universal caregivers are compensated more for the fact that they are doing this extra labor. Because we are not operators ourselves, we don't set the wages, but we recommend that they be at least 15 to 20% higher than the prevailing wage for a CNA in the market. And to be clear, this is something that we have done in states across the country. There are even unionized greenhouse homes where operators have worked with unions, especially in the Northeast, to clarify the roles, kind of explain what's going on, and realize that in the end, this kind of model benefits everyone. So that gets us to the point of this report that Poki'i and I worked on. It was for the state of Maryland. So the state of Maryland approached us, and they asked a question that I get all the time, which is, what are other states doing to incentivize the construction of new nursing home infrastructure, changing the culture of existing communities? And so this is really the problem, and it was a problem in Maryland, and it's a problem in every state. Most people don't ever want to move into a nursing home or see a loved one in the setting. There was a Gallup poll last year that I think said that maybe, I think under 10%, I think maybe even under 5% of people said they would feel comfortable either living in a nursing home themselves or having a loved one live there. The problem is, as I mentioned earlier, there's little incentive for providers to change. We get the system that we pay for, and we continue to spend a ton of money on this system that kind of everybody agrees is outdated, and especially post-COVID, is undesirable, and is really outdated. Most nursing homes in this country were built in a very brief period in the 60s and 70s, right after the creation of Medicare and Medicaid. There was kind of a little housing boom for nursing homes because suddenly you could get government reimbursement for it. That's gone. There's no real incentive to do anything differently. Another thing that I want to emphasize here is that we love home and community-based services. I never want anyone to come away from one of my presentations by thinking that we are nursing home partisans or we're somehow involved in the nursing home lobby, because the nursing home lobby can very often see home and community-based services as a threat. We don't see that. We think that a robust continuum is what is necessary, but there's always going to be a percentage of people who, for whatever reason, would either prefer to live in a communal setting. Loneliness and isolation are big problems that COVID revealed. And some folks don't want to be, especially if you're aging solo, especially if you live in a rural area. It can be a very isolating life to only have visits from a home care aide. And so there will always be a certain percentage of people who need care in a communal setting. And how do we build a new continuum where, which is one of our missions, every elder can live in the setting that they want. They can receive high quality services and supports in the setting that works best for them. Another example is in urban areas. If you live in a 6-story walk-up apartment, you may not be able to age in place there very well. It may be a very isolating life. So again, keep that in mind as we go through these. The reality is that we do not face a binary choice. This is one of the things that really frustrates me, is a lot of times when you talk about, sorry, I just had to move my my thing there, was blocking my slides. We don't face a choice between sort of a free status quo and some really expensive alternative. It's a point that I made earlier, but it's a point that I like to hammer home. The number one question is always, what does something like this cost? Well, keep in mind, you are spending a ton of money on nursing homes as it is, the state Medicaid program, Medicare. I want to give a big shout out to Hawaii for providing those utilization statistics on the state website. It was so incredible. I kind of nerded out earlier today and I went through them. They were all easily accessible. So something great. Not every state has this. There was data from 2023 that showed that occupancy at traditional nursing homes at long-term care facilities in Hawaii is only 75%. That's a low number if you're a nursing home operator. At the same time, there were 510 unstaffed beds in the state, mostly due to staffing shortages. So as you can see, there's regional variations. The average of 75% doesn't tell you a lot in any size state, because the nursing home demands are so regional. There could be markets that are overbedded, markets that are underbedded. But it really does show you that it's kind of a microcosm of what we have nationally, where we have 15,000 nursing homes, none of which are going to really be that full. And again, post-COVID. And so you do have an opportunity there to kind of start shifting funding, shifting money toward the things that people want and away from the things that they don't want. So how can Hawaii spend that money that you already spend every year on something that is higher quality, more empowering? And how do you build that into a comprehensive set of options? So these were the recommendations that we came up with. And again, they apply to every state. I've given presentations on this report to folks in a bunch of different states. They're universal. And really, all of these up here are just to provide ideas of what you could do to incentivize development, using examples based on what has been done in other states. So number one is certificate of need reform. This is a big issue that comes up. We, as the Greenhouse Project, have been trying to find a partner to build a flagship community in the suburbs of Washington, D.C. That's where our organization is based. And we would love to make a showplace for federal lawmakers to come and see. But we haven't really been able to get the bed licenses. It's a really ongoing issue. A lot of states, it kind of provides an artificial cap. The CONs, the certificates themselves are valuable. It prevents people from, it's like a self-sustaining thing where if you want to do something different, lawmakers in a lot of states say, we need to do something different, but you can't bring somebody in to do something different because the folks who are already in the system control the bed licenses. For years and years and years and years, a bunch of different reform experts have recommended full repeal, but that's really politically challenging. And there are some benefits to CON too. I don't want to make this a whole conversation on CON. But exemptions already exist in Maryland, where we did this report. And many other states have used CON carve-outs to encourage small home development, private room development, things like that. Ooh. Sorry. For some reason, when I go on full screen, my cursor disappears. So here are some examples of, in other states, how they were able to make exemptions to the CON, not get rid of the CONs entirely, but how do you make an exemption? So in Indiana, for example, any community with 50 beds or fewer, you don't need to have a CON. You don't need to go through the CON process. You can move outside of it. Rhode Island, a couple of years ago, they had a bed moratorium, so no new beds anywhere in the state. But they put in a moratorium where they exempted greenhouse, Eden alternative, other small house models from that moratorium. And under that, we actually had a community, nonprofit community, St. Elizabeth's, that built a greenhouse community in Rhode Island. Importantly here, they repealed that moratorium entirely 2 years ago. And in that time, they have received no new applications for bed licenses. So I know that's one of the concerns, one of the reasons why CONs stay on the books. Lawmakers, policy folks are rightfully concerned. You don't want to flood the zone with a bunch of operators who really aren't good. You don't want to give away your licenses to just everybody. But so far in a year and a half, they have not gotten any applicants. Maryland, and I use this example pointedly, is that they already had a bunch of different exemptions on the books. So for example, if you are in an area where there are no nursing homes with 3 or more stars on the 5-star quality rating, you could build outside the traditional process. If you want to add incremental amounts of beds, which is no more than 10% or 10%, no more than 10 new beds or 10% of the total, you could do that outside of the process. Or if you're trying to fully replace a building that had 100 beds or fewer, you can go outside that process. So there are creative ways that you can say, hey, we obviously don't want A, bad operators, or B, operators to come and build exactly the same failed model, but here are some ways we can encourage new development differently and pointedly. Medicaid rate add-ons, this is another really big one. Relatively small increases to the household, to per diem Medicaid rates have spurred big change, specifically in Arkansas and Ohio. Crucially, again, this is not a blanket rate increase. I know that any talk of increasing Medicaid spending is politically very challenging. And I also know that for decades, the refrain among the nursing home industry has been, just give us some more money and it'll all work itself out. And that's not what we're trying to say. Is it only rewards providers that are willing to do something new, something different, and that there have to be, guardrails to make sure that that money is spent properly. Now, they can be paired with bed delicensing to right-size that nursing home capacity. So that's why earlier I was talking about how, the nursing homes are only 75% full. There's probably operators in Hawaii and elsewhere who might have a building with 200 beds. They know they're never going to fill them again. But what's a way to kind of achieve that goal of downsizing that bed count while actually doing something differently? And so Arkansas, all the way back in 2009, which feels like a different political world, but they were able to get a $4 to $5 a day add-on for small house homes. They did this through a state plan amendment. And since then, it's actually now applies to all private rooms. So you don't actually have to follow just the greenhouse model. If you provide any kind of private room care, you get that rate add-on. Whether that's a good idea or not, it's not for me to say. I don't live in Arkansas and I'm not a policymaker there, but just full disclosure. The additional funding there comes from the federal match, which was really key in getting that through. In 2009, Arkansas had a Democratic governor, but still in the South, a conservative Democratic governor. So there were concerns about increasing Medicaid spending. He made everybody happy by getting most of that money from the federal match. So again, that's an example of a win-win-win where every stakeholder kind of gets a little bit of a win. The operators get a little extra money to cover those capital costs. The governor gets to say, okay, hey, I did this without increasing state spending too much. And again, there's guardrails in place to make sure that the money's not just going to anyone. You actually have to build something different. Ohio, this is a new one that was very exciting. They actually just, this past year, they got it through, I think it was passed through the legislature, and then it was recently just approved by the federal government through the state plan amendment. They got $30 extra a day, per resident for fully private rooms, 20 for what they call private occupancy rooms that are not fully private, that would have a shared sink toilet. So imagine 2 private rooms that share a bathroom. You can get $20 a day from that. Crucially, operators have to already have those private rooms or relinquish bed licenses to create them. So if you have a 100-bed nursing home, you can't just put up a wall in the middle of all your rooms and say, okay, hey, I did it. Now give me $20 a day with the shared bathroom. It doesn't work that way. So you have to again, you either already have private rooms like our partners at Otterbein Senior Living, which operate a bunch of greenhouse homes across the state, or relinquish those bed licenses. And that's another key issue as you think about right sizing. Nursing home operators never want to give up those bed licenses because they're a commodity. They grant you the ability to get Medicare and Medicaid reimbursement. This way, again, everybody wins. The state gets the state gets to reduce the overall bed counts. The operator gets a little bit of money for relinquishing those bed licenses and building new infrastructure. And again, there are guardrails. You can't just do this. You're not just giving extra money for them to do the same things over and over again. And again, 24 states have pay for performance or Medicaid value-based programs. A lot of them, most of them do not really focus on the physical space, but a lot of them do incorporate person-directed care practices, stuff as simple as, do residents have a choice of what to eat when they wake up, or are they being woken up at 5 in the morning to take medicine because that's when it's easier for the nurses to do it. And so if you do person-directed care practices, you get some rate add-ons. Kansas has a very interesting program called PEAK, P-E-A-K, that I suggest you take a look at if that's if that is of interest to you. State pilot program. So we've got 5 of these, and then we'll be done. And then I would love to answer your questions. I see some in the chat. So we're on 3 of 5. But what you can do is you can create a state pilot program. If all these seem a little too daunting, you can follow the lead of some other states and the federal government in saying, let's create a program and see how this works. We can study it. We can see what works, what doesn't in our unique state with our unique challenges, and then we can try to replicate it across the state. So you could do it through a grant, tax credit, forgivable loan, any other financial pilot, collect data on outcomes, use the federal and New York program that I'll talk about on the next slide as a guide. And then also you can say, you know, what works in one part of your state might not work in another. You can create a program. For example, in Maryland, they were very interested in this idea of having one in a rural area, one in a city, one in the suburbs, trying to see how can we really make this work and adapt it to different areas. So on the federal level in 2021 and 22, there were bills that would have created federal pilot programs. Some substantial asks. Unfortunately, it was kind of dead on arrival because of how much money they were asking for and how gridlock things can be in Congress. But it would have created where operators would have to apply, they would get grants, and then there would be significant guardrails to ensure that money is spent properly. They had some provisions there where they would have to serve a certain percentage of Medicaid residents. Priority would be given to historically underinvested areas. One of the bills would require the nursing homes to operate as greenhouse homes for 20 years in order to receive that money. So I highly recommend you take a look at those because they provide a good blueprint for how you might be able to do that on the state level. New York, where I live, we have a $50 million grant program currently open. It would to encourage what they call either physical transformation of an existing nursing home, so renovations, or construction of new infrastructure, and that's through the state. New Jersey, recently they had a big report. Somehow it took them this long after COVID to produce a task force report, but that was one of the big recommendations, was talking about a state demonstration project. They mentioned greenhouse models, and they also mentioned dementia care villages as potential ideas, which also a great idea. Not here to say that you have to do greenhouse. We think our model is great, but there's lots of other good models out there as well. California, actually, they created a whole new set of standards under their pilot program, regulatory standards. Unfortunately, they didn't put any money with that. So it's been slow going, but we do have partners at a community in Southern California that are currently winding through that process. Seeing is believing. I highly recommend that if you ever get a chance to come visit one of our communities, either our communities or someone else's communities, can be difficult to really picture what we're talking about. But once you see that difference, it did it for me. You know, I actually started working at the Greenhouse Project before I had a chance to tour a home because it was during COVID. And even though I was fully bought in and I had known a lot of the folks at the organization and was familiar with their work, it didn't really click for me fully until I got to visit. So I'll just shout out 2 really cool examples. One of them is Tomei Rivertown in Detroit, where they kind of built a whole new model where it has assisted living greenhouse homes, independent living apartments, affordable independent living apartments, and an on-site PACE center that serves folks who live all across the community, right in downtown Detroit, all covered under Medicaid. They're really breaking the mold there. They really created their own category of what they're doing. And I'm just so honored to be a part of it because I think it's a unique way of tackling the challenge of how do we create a full continuum, but not have it be this private pay, very expensive campus. And then Otterbein Senior Life, I mentioned, they were influential in getting those rate add-ons. They have a network of 50 small homes across the state that were actually initially independent of the greenhouse model, but they came into our fold. They met our standards. And so we welcomed them about 2 years ago. And then again, finally, number 5 is a streamlined regulatory process. One of the things I emphasize, and it's been a challenge, we've been in more than half the states in the country, I think about 35. We've worked with we've worked with regulators in those states, and it can be very difficult sometimes to explain that the what we do at Greenhouse Homes matches the intent, if not the exact letter of the law. Because remember, the regulations were retroactive. They were designed to regulate the care that goes on in traditional facility style nursing homes. And so I always say that if aliens landed and you just gave them the rules on how to run a nursing home, they would only ever build a place where you wouldn't want to live, because the regulations are a reaction to a lot of the bad things that are happening in traditional facilities. So we recommended, figure out a way, and I know that this is a challenge because there's lots of different state organizations that oversee nursing homes. There's the funding piece and there's the regulatory piece and there's state and federal regulations. But we really recommend, create an interdepartmental process to make sure that, if there is a provider out there doing cool stuff, you can kind of quickly and thoroughly resolve gaps between the letter and the spirit of regulations. And then ultimately, as they did in California, develop a new framework that makes the household model the standard and make sure that the regulations reflect that. And I always have this disclaimer here: we are not calling for the relaxation of rules regarding resident rights to safety, autonomy, right to relief in cases of abuse, neglect, and fraud. I think the conversation around regulations in nursing homes has been incredibly fraught over the years. It tends to be, the industry says we're overregulated, advocates say we're underregulated, and our argument is that the regulations are necessary, but the regulations are designed to oversee a model where nobody wants to live. And I always say that, when I'm 80, when I'm 90, I don't want to live in the most technically compliant 3-bed nursing home room, because that's, I don't think, really what I want and what a lot of people want. So that is the end of my presentation. I have a little shout out here. I'm part of the Moving Forward Coalition. It's a group of industry stakeholders, researchers, policy people, and we have monthly meetings where we talk about these issues across states. I've learned so much from my peers in other states. It's the small home work group. So my email address is there. And if you're interested in learning more, please join. And thanks. And I'm happy to answer any questions that may have come up. How was that on time?
Very good. Thank you, Alex. Really appreciate that in a nutshell and very quickly, really the whole concept, as well as some examples of what actually is happening and what we can learn from. I see, I'm going to open it up to people who have questions, but I see that we have one in the chat box from Audrey. The cost per resident, private pay or Medicaid, what is the difference in cost per patient? Do you have any data on that?
I don't have any specific per patient cost, just because it varies obviously by state, but it is typically in line. The operational cost is in line with whatever again, we have operators that are receiving 80% of, their revenue through Medicaid. So that cost is roughly the same as what it would be in a traditional nursing home.
So I guess we're all looking at the cost. I mean, we're looking at private.
Obviously.
You have your own unit. You've got CNAs who do everything for you. So you pretty much have a private butler, I guess you can call it that, right? That does everything for you. The cost must be more. And how do you address that so that everybody can get this kind of care?
Yeah, and so again, that is an ongoing challenge. And so I don't believe it's $15,000 per month. I see that. And again, it varies, and it's not, during the day there are 2 to 3 caregivers per home. There's a registered nurse that will serve 2 homes during the day and 4 homes at night. So it's not personal, it's not like the same as having a personal care aide. It's not, you have 12 people in a home. It's not 12 one-on-one aides day in and day out. It isn't that. The cost per day, again, we have operators that do private pay, and that's pretty much a market rate for whatever the nursing home would be in that marketplace. But as I said, we have operators that do 60, 70, 80% Medicaid, where the residents are not paying anything at all. It's all covered under Medicaid, or they're just paying whatever copays they have. Part of the challenge, obviously, is getting to the point, the way that I frame it is that the real additional cost that is incurred is the capital. So the capital expenses, that's where the cost to the provider really is. On an ongoing basis, it's cheaper to operate the nursing home for a variety of reasons. The lower workforce turnover, residents actually eat the food. There's less food waste because the food is prepared fresh. The food is prepared to their liking. We have organizations that have had to seen substantial reductions in spending on dietary supplements because people are eating and gaining weight. So there are, that's the big challenge, is getting people to, once you get it up and running, it's arguably the same or even a little bit cheaper to run than a traditional nursing home. You do have less overhead, but it's that capital cost, either retrofitting an existing building or building new, where some of that comes in. And that's why, we really focus on those Medicaid rates or, grant programs. Because once, again, for example, the $4 to $5 extra in Medicaid dollars that they got in Arkansas, that was enough for our operating partners to get traditional financing. The big issue that a lot of finance people have with lending to organizations, and my old job, I covered this, is this perception that Medicaid rates are not sufficient, even for traditional nursing home care. And we could argue for days over whether that's true, whether that money is being extracted via profits or whether it's actually going to where it should. But small increases in those per day rates are usually enough to satisfy investors. And again, part of that is also occupancy. I don't think I touched on that in my presentation, but it sounds crass, but if you're looking at it from a purely financial standpoint, heads and beds, that's what they all care about. Is an empty bed is not making any money, but a full bed is. And so there's increased demand. Most of our greenhouse homes are more than 90% full. Some have waiting lists. So that's another area where you can recoup some of those costs because you have less downtime, you have fewer empty beds.
So what is the capital cost, in terms of having a structure already, a building already, and you're retrofitting versus something new? What are the differences, or, because you're now making individual units with individual doors, I guess, to a unit. What are the kind of capital costs? I mean, I know it's sort of, it ranges, but what are we looking at that's different from traditional nursing homes or assisted living homes?
Sure, yeah, and it is a range. So we did a more in-depth survey about 5 years ago, and it was anywhere from $260 per square foot to $520 per square foot. And again, that is, that's including operators in extreme rural areas, that's including operators in the outside of Boston. So it's a very wide range. The good news is, the design considerations are not that complicated. We built greenhouse homes. They're kind of standard designs that have been used for the small, the traditional standalone small house homes. Part of the reason this is so difficult to compare is that we're not really building new nursing homes. I can't think of the last time a traditional nursing home opened in the Northeast that I've heard of, where I live. So it can be hard to compare apples and oranges. There's a lot of different considerations depending on site, labor costs, all of that, but it really isn't that much more complicated, especially if, you're doing the greenhouse, the vertical style model. I know the one big thing people always say is, well, you're pouring 6 foundations, you have to deal with plumbing and all that stuff. We have had operators make it work standalone, but if you're doing maybe a mid-rise, high-rise, it would be comparable. It's the same general idea.
So I see Audrey back on again. She says the average nursing home bed per day is about $400 to $500. You see that? For these are nursing homes in Hawaii. But 70 to 80% of that is operating cost. Is that kind of,
Is labor.
yeah, labor? Is that what you folks are finding too in your greenhouse?
Labor is always, I mean, again, I'm not going to say that we have lower turnover, we have greater workforce satisfaction, but labor is always an issue. It is the number one, finding people, finding good people. And yes, that would be. And again, as you know, as I showed on the slide earlier, really the theory on the operating cost side is shifting as much of that money toward labor as possible, because that's where the difference is made, right? It's the people, it's not the housekeeping organization or the food service organization, all that overhead cost. So it's really about shifting that, making sure all of the money, or as much of the money as possible for your budget, is going where it really matters.
So are there any other questions from you all? Just either raise your hand or use the raised hand sign. I don't see anyone, or chat. Pokey, you want to add something? Question?
I just want to really thank Alex for the discussion and everybody for your questions. And if everybody has more questions and wants to reach out, please feel free to reach out to any of us. I think Alex said he's going to send his slides. Alex also mentioned Jill from Otterbein, and I can send those slides out to everyone. And hers really looks at some of what Alex was talking about in terms of financial cost. I know that is everyone's number one concern, as it should be, and that's a factor we have to figure out. But I just want to share that I have had the privilege of visiting green homes on the East Coast, the original home model, as well as the buildups, and to see it in action with the universal workers, which isn't not unknown to Hawaii, right? In our arches and arch twos, we have universal workers if they're unified, and many of the concepts of the greenhouse. And so, just please reach out if you have questions. It sounds like I saw Kenny's one, 2 to 12 residents. That all depends, right, on how the home is built and state by state. But when you see it in action and you walk in and you're watching it happen in front of your eyes, it is definitely an experience, someplace that I'd want to put my father, that I would have put my father if I still needed a place. So finances always have to be worked out, and I'm a money person, but I just really want to encourage people to be open to the idea also.
Thank you, Pokey. Donald, there's a
thank you, Ali, for the presentation, Donald. Is it possible to have the slideshow emailed to me in an alternate format, like a text format, so I can view it as a blind individual? That's all. But thank you for a wonderful presentation. Thank you.
Oh, sure. Yes, thank you. I will. I can work with Pokey on that.
Great. Any other questions? Well, thank you so much, Alex. Really appreciate the presentation, the slides. Very, very good. We may circle back to you. I know I see somebody from Pabia. Is that you, Rick? Interested in what they're doing? We've been talking about person-centered care, but seeing it in reality in terms of residential is really great to see.
Yeah, we had a whole discussion about this today as a possible bill to kind of go after in Pabia. So your timing here, Alex and Pokey, was perfect. So I was asked to actually ask about it, and you presented it. So I got the question: where we go next?
So Alex, are there so when these states, and you say it's really private basically and getting the funding and so forth, but is there anything in any of the states that you've been in that had these greenhouse models where legislation helped facilitate its development? And maybe that's the kind of language that Rick's asking for. At least we can put it in front of the legislature to explore this model.
Yeah, so really any the examples that I gave were all different pathways toward making that happen. So whether it's having the CON exemptions, whether it's the Medicaid rates, whether it's as in New York, where New York wasn't a legislature, that was just it was a governor's office issue. But again, there's lots of levers you can pull. Part of my challenge working for the national organization is I don't know nearly as much about every state's political process, where the power is, it's very complex. But first of all, Rick, I would love to chat more. I put my email address in the chat there, so please feel free to reach out with any questions. But yeah, there are a lot of different pathways that can be taken. There are a lot of great examples, either through those Medicaid rate increases, the grant program, even just changing some of the design and life safety codes, things like that. A lot of it has been there. So, and I see Pokey E is adding in there. So obviously, Rick, Pokey E, I would love to follow up more on this later.
Yeah, we'll talk more, definitely. Appreciate it.
And if it's a
Absolutely.
certificate of need, and if they are challenges, I think we could look at that. That is state law. That can be sort of relaxed a bit if we have some innovative models that we would like to explore or pilot. That would be, something maybe Rick Pabia can look at. Okay, well, thank you so much, Alex. Really appreciate all your expertise and sharing of these models. So we will probably have people circling back to you and others. And Poki, thank you. So
I welcome it. Thank you.
Aloha. Okay,
Thank you, everybody.
And the segue to our legislation is that we are going to be asking you for proposals. So it's very timely. Rick Pabia can be looking at how we might have some of these more innovative models. So we're soliciting bill proposals now for the 2025 legislature. And we're asking you to submit your proposals, or at least concepts, by October 31st. And that's the day before the next Kupuna Caucus meeting. So if I think all of you that are on and others, Charles put a link for submitting your proposals. So if you would look at your emails and then use that as the link to give us your proposals, we will get all of those together. And then at the November 1st meeting, we will let us know if you want to present. So then we will put you on at the November 1st meeting so that you can persuade others to vote for your proposal, because we are limited to 5. And we will take the top 5 priorities based on your votes. So I encourage you all to put your concepts together. You don't have to have the exact language, but enough to justify why you want the bill and what the bill will do. Then we can tweak it, once it gets, if it's one of the 5, then Corey and I can work with you guys on it in terms of getting a bill drafted. So the date is October 31st is the deadline for your proposals. And then at our November 1st meeting, we will hear all the proposals, and then we'll have online voting for the top 5 proposals sometime after that meeting. Any questions? Okay, then. Well, oh, okay. Oh, what is that? Is that hand raise or hand clapping?
Hand clapping. Hand clapping.
Okay. Well, thank you all. I think that we have come to the end of our time together, and I just want to thank all of you for being on, for your input. Aloha, Corey, you want to say aloha?
Thank you, everybody.
Okay, aloha.